I too want to thank the organizers, and really it's a wonderful venue to have a meeting. I, of course, normally lose my voice when it gets dry in the altitude, so please bear with me, and if you can't hear me, I'll try to speak up. Okay, so when these data were put together, it was clearly shown that myeloma is the most frequent malignancy to involve bone, with about 85% of patients having bone involvement with advanced disease. And that was in excess compared to lung cancer, breast cancer, or prostate cancer. But the important point, although these survival data have now improved for myeloma, but I don't think they've improved much for the other diseases, is that once you had the bone involvement with a malignancy, you're essentially incurable, although that's now was debated at this meeting in terms of myeloma. But everyone's been arguing, well, is bone disease really as common as it used to be because everyone's getting diagnosed so much earlier? Well, this is a very recent series from the Mayo Clinic from Greenberg and coworkers that was just published in Leukemia, and they looked at presenting features of patients at diagnosis. And I'll just point out 336 of their 484 patients had bone disease at diagnosis, and a third of them had bone diseases that what they call their myeloma defining event. So it appears that the incidence of myeloma bone disease, although it's probably lower at some places where people get diagnosed much earlier, is still a very persistent thing. And this is a very interesting article because it ties genotype of the myeloma to incidence of the different characteristics, but I will point out that 414 patients really have a lower incidence of myeloma bone disease than others. Now, myeloma bone disease is a very ancient disease, and this is a skeleton from Nubia from about 200 AD, and this patient, I guess he wasn't a patient, but has very clean punched out lesions characteristic of myeloma bone disease without any reactive new bone formation. And that is the problem with myeloma. We have bone destruction, but no bone repair. And Melton and co-workers from the Mayo Clinic reported back in 2005 that at diagnosis, about 15% of their patients already had a pathologic fracture, and this increased to about 60% over a 10-year period. Within 1 year of diagnosis, about 40% of these patients had pathologic fracture. In a more recent series from Germany using low-dose whole-body CT rather than skeletal surveys, they too found a fracture incidence of about 14% per year in these patients. But what I want to point out is that the percent of patients with fractures shown by the colored bar was pretty much the same whether you were progressing with your myeloma, you were in remission, and most of these patients were in partial remission who had fractures, or if you had stable disease. So they argued that fracture by itself is not a definition of progression in myeloma. And I would agree with them because once your bone density gets below the fracture threshold, you're at risk of fracture whether you have active myeloma or not. But probably, as Dr. Palumbo pointed out, if you don't have myeloma in your bone, it's going to be a little harder to fracture. The importance of fracture is that it both impacts your quality of life and it adds about 20% to your mortality compared to patients who don't have a fracture. So preventing fractures is really critical in myeloma. So myeloma bone disease is really so horrific because the normal bone remodeling system where osteoclasts remove damaged bone, and we all damage our bones as we walk around, is coupled to new bone formation at sites of previous bone resorption. When you're young, you make more bone than you remove, and when you're old, like me, you lose more bone than you make. But in myeloma, you have tremendous osteoclast activity and almost no new bone formation. And this persists even when patients are in long-term remission. So you rarely, if ever, heal your lesions in myeloma, although there's been anecdotal reports using variety of novel agents that appear to stimulate bone formation. So why is myeloma so horrific? Because myeloma cells make a variety of factors that directly or indirectly stimulate osteoclast formation, including macrophage inflammatory protein 1 alpha, interleukin 3. In addition, they induce marrow stromal cells to make rank ligand and interleukin 6, which drive osteoclastogenesis. Osteocytes in myeloma make rank ligand, and really also may be the major drivers of osteoclastogenesis in myeloma as they are in normal bone remodeling. But on top of this, myeloma cells themselves produce inhibitors of osteoblast differentiation, like DKK1, IL-3, which we'll talk about, soluble frizzle-related protein 2 and 3, IL-7, TNF-alpha, and myeloma cells have been reported, like osteocytes, to make sclerostin. And there was a recent paper from China, which also, like the Italian group, has identified sclerostin and mononuclear cells from the marrow. The other thing that's being made is activin A, which is made by osteoclast marrow-stromal cells, and as I'll show you, tumor-associated macrophages in myeloma. Now, our current treatment of myeloma bone disease is well known to this group, and I won't belabor it. The gold standard is bisphosphonates, which are potent inhibitors of osteoclastic bone resorption. We have surgical procedures to repair vertebral fractures like vertebroplasty and balloon kyphoplasty, which in a meta-analysis is shown to be equally efficacious, but better than, at least for balloon kyphoplasty in a randomized controlled trial, than just standard of care. Radiotherapy can be used to treat bone pain as well as fractures. But the key is if we could cure myeloma, we'd probably get rid of myeloma bone disease. And I'm looking forward to that happening, probably not in my lifetime, but maybe so if you guys work a lot harder. Okay, so bisphosphonates, I told you, decrease bone pain. They're analgesic to bone. And the reason why they're analgesic to bone is they block osteoclastic bone resorption, which releases protons into the marrow microenvironment, which stimulates nociceptive receptors in the marrow, which induce pain. They also reduce bone-related complications called skeletal-related events by about 50%. And the current recommendations, also by me, are that all patients with symptomatic myeloma, regardless if they have bone disease, should be receiving bisphosphonates. And that's based on the myeloma 9 trial, which showed a survival benefit for patients, albeit mostly the patients with bone disease, but that also showed you prevented the fractures even in patients who don't present with bone disease. There's renal toxicity and osteonecrosis of the jaw to worry about with bisphosphonates, although now with dental prophylactic regimens, the incidence of osteonecrosis of the jaw has dramatically been reduced. I can remember 10 years ago when I'd see a patient with ONJ probably once a month or something. Now I haven't seen one in, I don't know, a couple years. You have to monitor vitamin D levels because more than 50% of patients with myeloma are vitamin D insufficient or deficient. And you have to consider, and if you read the package inserts, you should give patients vitamin D supplements and calcium. How much is open to debate, and we won't probably go into that today. But among the drivers of osteoclastic bone destruction, the major one is rank ligand, which normally is produced in very, very low levels in your bone marrow by T cells as well as by marrow stromal cells and by osteocytes. But in myeloma, it's tremendously upregulated, while its decoy receptor osteoprotegrin, which normally is in vast excess to rank ligand, is reduced. So you end up with Swiss cheese for bones instead of a nice lamellar bone. And this is seen in any lytic bone disease. And Evangelo Turpos has shown back in a nice paper in 2003 that your rank ligand OPG ratios determine your survival. So that if you have a normal one at 5 years, 89% of these patients were alive, and you have a very abnormal one, your median survival was about 24 months. And this may reflect simply tumor burden, although I don't think that was correlated in that study. And now we have denosumab, which is a human monoclonal antibody that binds rank ligand. It's very specific for human rankle, has very high affinity, and it's a very potent inhibitor of both osteoclast formation and activation. And there's been a phase 2 trial by Dr. Vidge, which showed that you could inhibit bone events but had no effect on tumor burden. And the phase 3 trial, which was a randomized double-blind study of denosumab versus zoledronic acid in patients with a variety of lytic bone metastases, but not breast cancer or prostate cancer, and about 200 myeloma patients thrown into the 2,000 patients in this trial. It was shown that denosumab was non-inferior to zoledronic acid in preventing first SRE on study. Overall survivorship for these patients was very similar, but was inferior for the myeloma subgroup. and that's been debated as to why that is, but it resulted in Amgen now doing a 1,000-patient randomized controlled trial of denosumab in myeloma. O&J rates between the denosumab and zoledronic acid were similar, and because denosumab is more potent than zoledronic acid, hypocalcemia was greater in patients receiving denosumab. But the issues with both these therapies are that they have about the same rate of osteonecrosis of the jaw in randomized controlled trials. They all decrease skeletal-related events, but patients still progress at a slower rate. But the big problem is they induce no new bone formation, so you never heal a myeloma lesion. So that right now, our current optimal therapy for myeloma bone disease is, of course, treating myeloma, which we're getting better and better at. We now have pretty good therapy, in fact, very potent therapy to block osteoclast formation activity. And what we really need is good therapy to reverse the osteoblast suppression and develop anabolic therapies for bone. Now, there's a couple novel agents that have been developed to target what is now known about the pathophysiology of myeloma bone disease. DKK1, for example, and soluble frizzle-related protein 2 are inhibitors of the Wnt signaling pathway that is absolutely critical for osteoblast differentiation. And DKK1 and soluble frizzle-related protein 2 are secreted by myeloma cells and also induced by myeloma cells in the microenvironment. John Shaughnessy's group has shown that gene expression of DKK1 correlates with the extent of bone disease, and there are now ongoing clinical trials of an antibody to DKK1 in patients with active myeloma. That trial is complete, but it's not been published, and it was done predominantly in patients receiving melphalan and prednisone in Russia, and there's now one for high-risk smoldering myeloma as well. And the reason why this trial is ongoing is work like this. There's work from Nikki Munchie and Shmuel Yacobi in 2 different papers, which showed if you block DKK1, you reverse the bone loss in these animal models, and you also reduce tumor burden. Now, IL-3 is another major driver of osteoclastogenesis and suppressing bone formation. It's bifunctional in myeloma. It's a potent inducer of human osteoclast formation, and it's an inhibitor of osteoblast differentiation. What's interesting about IL-3 is that it's an indirect inhibitor of osteoblast differentiation. What Lori Ehrlich in my lab showed back in about 2005 was that at levels you find in patients, and about 70% of patients have been found to have high IL-3 levels, you can suppress osteoblast differentiation. But if you take away hematopoietic cells, in particular marrow macrophages, out of this gamish, you now lose IL-3's ability to suppress osteoblast differentiation. You add them back and you restore it. So we became very interested in trying to understand what is this indirect substance. It's not TNF-alpha. And in collaboration with Nick Giuliani at Parma, we did gene expression array studies on marrow macrophages from patients with myeloma normals and treated them with IL-3 and found that one of the major genes upregulated was activin A. Now, activin A is a bifunctional bone active agent. It stimulates osteoclast formation, and it's a potent inhibitor of osteoblast differentiation. And Nupur Raji has really published some nice studies on activin A inhibition of osteoblast differentiation, and she's now running a trial of an activin A receptor antagonist in combination with lenalidomide in patients with myeloma. Now, we were very interested in seeing if IL-3 really was inducing activin A in vivo. And what we showed first, and this is Rebecca Silverman's work, which was just published in Leukemia, has shown very nicely that if you treat even normal CD14 positive cells from the marrow, you can induce activin A, but you really can induce it at very high levels in TAMs from myeloma patients. And this can be recapitulated in vivo. If you inject IL-3 over the calvaria of a mouse, you get loss of osteoclasts compared to saline, and it's totally blocked by anti-activin A. So this has led to Rebecca developing a phase 2 trial, which will be starting later on this year, which is going to be studying the activin A receptor antagonist sotatercept, which I can never pronounce correctly, In patients who are 2 years out in their myeloma who have either in CR or have stable disease in PR, stable PR, and who have received zoledronic acid but will now have it stopped, and we'll find out if we can really induce bone formation with this activin A antagonist in patients with myeloma, and whether their osteoblast suppression, which appears to be protracted, is reversible at all. Because this activin A receptor antagonist is a pretty potent inducer of bone formation. This is in cynomolgus monkeys. Here's vehicle, and here's activin A receptor antagonist treated animals. That's ACE-011. You can see that's pretty dramatic new bone formation, and this occurs in about a month. And Peter Croucher's group is also shown in the 5T2 model of myeloma that if you use the rodent equivalent of ACE-011, you can block bone destruction, actually build bone in this model. But I want to remind everyone that models of myeloma, at least rodent models, you can almost cure myeloma, you can build bone, you can do lots of things, and not all of them will translate into what occurs to patients, even though I make my living doing that. The last thing I want to talk about, just to give you some insight into some new stuff, that you have to remember adhesive interactions between myeloma cells and marrow stromal cells result in both increased tumor growth and as well as increased bone destruction and osteoblast suppression. And we became very interested in trying to block the signaling pathways in stromal cells induced by these adhesive interactions, because what happens when myeloma cells bind marrow stromal cells, you activate multiple signaling pathways, and everyone has their favorite one they like, and everyone has tried a single pathway antagonist with not a whole lot of luck. So we decided to target P62, which is sequestosome 1, which is a signaling platform where many of these signaling complexes are put together, and then they drive the production of many of the cytokines that are all near and dear to our heart in myeloma. And the reason why it's a signaling platform is it has 6 domains. It has a PB1 domain, which is for atypical PKC signaling. There's a ZZ domain, which binds RIP, and TNF-alpha drives atypical PKC and F-kappa B production. There's a P38 MAP kinase domain, a TBS domain that binds TRAF6, so it's involved in IL-1 rankle signaling, and there's a ubiquitin binding domain, which sequesters ubiquitinated proteins. Now, we have developed a small molecule antagonist of the ZZ domain, which we found using deletion constructs was mediating many of the effects of stromal cells on myeloma cell growth and osteoclast formation. And we found very interestingly that P62 also appears to be critical to myeloma viability because it has direct, if you use this antagonist, which is, remember, blocking protein-protein interactions, and it has a IC50 for myeloma of about 5 micromolar. So it's the first compound, and we need to really improve it. It'll kill myeloma cells, both murine primary or myeloma cell lines. It blocks osteoclast formation and differentiation. It has no effect on hematopoietic precursors or marrow stromal cells, but it blocks upregulation of VCAM1 induced by myeloma cells. It blocks IL-6 production, blocks atypical PKC signaling, but has no effect on P38 because it isn't involved in that domain. It's just a ZZ domain. And the only reason I'm telling you about this is if I can get this thing to work. Quit working. Can you advance the slide, please? Can you advance the slide?
Next slide, please.
Ah, we got it. It went out.
It's finished.
It's not finished.
You ran out of time.
Oh, I'm finished. Okay. Well, this was actually sort of interesting. So, I saw Keith Stewart yesterday doing shadows, so I thought that was really cute, but I'm not good at that. Hmm?
Give a slight delay.
Oh, it's like, oh. Well, we have to go back a couple. Can you go back a couple? Keep going. Right there. Okay. If I can advance, okay. So, but when we did in vivo studies, the drug is very well behaved. It has little toxicity in mice. We can get up to about 1 micromolar concentrations. But what we found that was really interesting was that it induces new bone formation only in myeloma-bearing bones. So that this is intratibial injection of the 5-TGM murine myeloma cell line, and it causes tremendous bone destruction normally. Instead, we have this dramatic new bone formation. This is micro-QCT. Even I can tell you that there's new bone formation compared to the contralateral limb. And if you give this drug to just mice, it has no effect on bone formation, and it has no direct effects on osteoblasts. It only affects in co-cultures of myeloma cells with osteoblasts. And this shows you in tumor-bearing bone, this is new bone formation to total bone. It's significantly increased compared to vehicle-injected animals bearing the tumor, and it's dependent on tumor score. The more tumor you have, the more bone formation you get if you're receiving the drug, and it has no effect on non-tumor bearing bones. Now, just to give you an idea of what kind of bone formation, this is what 5-TGM1 looked like in a tibia. They're actively destroying the bone, and there's very little bone formation, and you can't find an osteoblast if you were looking for one. This is if you give the P62ZZ antagonist. Here's myeloma sitting there happily because we're not at the IC50. But this is tremendous new bone formation next to the myeloma cells. You can see the bones being rapidly laid down because it's woven bone. You see lots of nice, juicy osteoblasts making bone, but only in myeloma-involved bone. And there's now osteoclasts coming into remodeled bone to make it laminar, so that we hope you're going to end up with good quality bone instead of pagetic bone or something like that. So I'll finally close, and I may have gone over my time, but I'll blame the slide delay, right? Okay. That number of the not-so-novel agents have really dramatic effects on bone. Lenalidomide, but not thalidomide because it's not as potent, and probably pomalidomide, which has also been shown to block osteoclast differentiation. And Suzanne Lynch has shown very nicely that it actually steals away the osteoclast precursor and drives it toward the granulocytic lineage. So it affects its differentiation pattern. And Greg Mundy's group originally showed that proteasome antagonists as a class can stimulate new bone formation by upregulating BMP2 in the marrow microenvironment and then driving RUNX2 expression to make osteoblasts. So that bortezomib and carfilzomib, as you've seen here, can induce new bone formation. The question is it transient? Is it sufficient? Remains to be determined. But Nick Giuliani reported in Blood in 2007 in patients giving bortezomib as a single agent, I think. I don't think they got dexamethasone. That if you were responded to bortezomib, you made new bone. And for a non-responder, you didn't make new bone. So that he found new bone formation in his cohort of patients receiving bortezomib. So I'll summarize and remind you that bone disease continues to be a major problem and causes severe morbidity and mortality in myeloma patients. We have new imaging techniques that are more sensitive. We heard about them yesterday. We heard about whole body MRI. We heard about whole body CT. That's probably that low dose. That's probably going to replace skeletal imaging, I think, once we get people to pay for it. Studies delineating the pathophysiology of myeloma bone disease have identified multiple potential therapeutic targets, and novel agents that target myeloma can also target bone cells. So sort of give you a laundry list of what's currently being worked on. Denosumab is in clinical trial. MIP1 alpha, which is a potent driver of osteoclastogenesis, binds predominantly as CCR1 on osteoclast precursors as well as on myeloma cells themselves. And there is a CCR1 receptor antagonist been developed by a couple pharma companies, and there was a nice paper recently in Blood showing that it works even after you have established myeloma. Anti-DKK1, we talked about. Bortezomib also lowers DKK1 levels. I told you about ACE001, and Nupur is really spearheading most of those studies. There's an anti-sclerostin antibody, which is very active in patients with osteoporosis. which is in preclinical trial. I don't think it's in clinical trial yet, is it, Newbert? Do you know? Yeah, and we've shown GFI1 as a transcriptional repressor of RUNX2, and there have been preclinical studies using a GFI1 antisense construct in vivo and shown that it'll reverse it. And these are all the people who've worked on this over the years. I won't go through all their names, but I want to highlight just Dr. Kurihara and Dr. Teramachi, who've done a lot of the work. And this has been my funding over the years, in which I'm very grateful for, and hopefully will keep in the future so I continue to have a job. I want to thank you for your attention, and I'd be happy to participate in the panel to answer questions. Thank you very much.